So today I'm kind of going to look from the perspective of how you all can help them be better prepared, whether it's anxiety, depression, or whatever, but especially that notion of anxiety, because almost everybody walking into primary care is going to experience anxiety. And sometimes in primary care, unwittingly, the people in the very settings are fostering some of that anxiety, not on purpose, but it happens. Okie dokie, let me see if I got this right. Yay. Okay, so last time we talked a little bit about nurse practitioners, PAs, and doctors. They are all the ones that are going to be doing the assessment, diagnosing, and prescribing. But the RN does do a head-to-toe assessment, and it does include some questions about mental health. But I can tell you, most of the time they're much more concerned about blood pressure and diabetes and flu symptoms and those kinds of things. And they're very quick to catch on to if there's been like a significant weight change or if there have been some big change in vital signs. And that's why I'm real excited that Dr. Sharp is here and doing the part with the screening tools, because that's incredibly valuable, but they need to get to know how to use them well. So one of the things that you'll want to be doing is working in primary care to help them know how to use you to really take care of that person to make it holistic. All within the context, of course, of safety. So when we think about anxiety in that primary care setting, we think about things like making an environment that's calm and safe for the individual. So when you go to your primary care provider, what do you notice that they've done to make it a comfortable environment?
Nice chairs.
Nice chairs, yeah.
They small talk, get to know you a little bit.
Yeah, they often, when you go into the exam room, they don't jump right in. They may ask you how you're doing, a little small talk, trying to establish that connection. Even if you're a regular patient, you may not have been there for months, and so what's been going on? What else? TVs are often on. That's a nice distraction. Yeah, you had your hand up?
Similar to that, but I was just going to say magazines.
Yeah, magazines.
Silly, but it's another distraction.
And hopefully they're not from 2003. That kind of thing, yeah. And in practices where they see children, there may be some age-appropriate little toys, that sort of thing. So they do make efforts. And then you go into the exam room and they may ask you to put on those lovely gowns, that sort of thing, or you may not. Today they're trying to think more about, is that really necessary given the reason of the visit? Because it can be a bit disconcerting. If you're really there to have your toe looked at, do you have to put on that gown? But then what happens is you kind of get left in that room, right? What does that do for comfort? So one of the things that we want to talk about is when you're creating that calm, safe environment is setting expectations and being present. It may mean that the staff who is checking you in will be able to tell you, the person coming in for care, that the nurse practitioner or the physician or the primary care provider is running a little late today, so can I get you anything while you're waiting in here? And then check in on them literally to find out, do they still need anything? And I'm so sorry for your wait, but it will only be about another couple of minutes. Setting realistic expectations, though, is real important. Because if you do have somebody that already has an anxiety disorder, this is not helpful. And if you don't have an anxiety disorder, this is still not helpful. So one of the things that you all can do in your relationship building with primary care, and I say providers as well as their staff, is have those kind of dialogues. What can I do as a mental health or behavioral health specialist to help you in your practice with your patients? Asking those questions, kind of informally, like going and having lunch with them in their setting, like a brown bag lunch, just to talk about those things. And the safety kinds of things. What are they concerned about? And you may be able to help a lot with that, because sometimes they're real concerned that if I have this person that's real anxious, I don't know how to take care of them. I don't know if they're going to bop me in the head when I go in the room, which they're not likely to do, but people have that imagination going for them. they may really welcome you talking with them about ways to interact with patients known to have depression or anxiety, especially with all the myths and misconceptions that fly around the news these days. I mean, I was appalled when one of our top leaders in the country referred to a shooter as that nutcase. That does nothing to help with stigma except, foster it. And it's our roles then to help with that in primary care. We can help those providers and their staff. Other things that help would be validation. If somebody's anxious, helping the staff in those primary care offices know to validate that is an important thing, because we want to acknowledge this is real. This is not something that you just came in and worked yourself up over. And then we think about, as Dr. Lentz mentioned, often in the primary care office, what happens is they're taking on the role of prescribing the medications. One of the things we want to be helpful for is really being cognizant of the benzodiazepines and how they're being prescribed for anxiety versus how the individual is using them. So if you're seeing somebody in your practice and you know they're on medication, you want to explore a little bit and have that communication. Which is better? Having an anti-anxiety medication, benzodiazepine, PRN, meaning as needed, or prescribed as a regular occurring medication? Oh, great. That's absolutely true, because the PRN tends to lead us down the road of abuse. But many primary care providers still provide it as a PRN medication. So you want to be on top of that, because they're going to be asking, are you still using it? Do you need a refill? You're going to be asking, how are you using that? And are you using it as prescribed? The primary care provider will have that red flag go off if they're asking for a prescription sooner than it should be. Okie dokie. So then we think a little bit about some of the goals. And again, they're not looking at DSM-5 in the same way that you look at DSM-5. They're going to look at, is this person got, do they have anxiety or not? They're not looking at all the various parts of that. And so they're looking at, if this person's coming in and they're all revved up, like psychomotor agitation and rapid speech, and they're not sleeping, they're looking at, can they get their vital signs back down to normal, and can they have a conversation with this person? They're also not maybe tuning into the fact that if they truly struggle with anxiety, they're not able to take in information at the same rate and have it stick. And so that's something that when you're having like a little lunch with the staff, you might reinforce or explore how to do that effectively. Because they're going out saying, I gave them a handout, I talked to them about this, because they're really, again, they're focused on diabetes and hypertension and that sprain or ache, the things that brought the person in. They may not be looking at there's an underlying depression or anxiety that is fueling whatever that presenting problem happens to be. And so in the interventions, it's keeping calm. Our anxiety can be very much contagious. And we know that, and so we want to help the staff. And maybe a little brown bag lunch to help the staff with self-care is important, because we ask them to teach self-soothing techniques. You can't teach something that you don't have. And again, acknowledging or being aware of their anxiety, whether it's situational, because they're about to have a procedure done and you want to help them anticipate, or because it's a true diagnosable illness. So right now, I'd ask you, when it comes to self-soothing, is just take out that little star, if you will. And I want you to unstick it, if you can, and put it on your index finger. And now just look at it. Take a few deep breaths, those that you all know from progressive muscle relaxation, that sort of thing. Breathing slow and deep. Look at the star. Take a look at which direction the top point is pointing, and look at the reflection from the light. And when you think you can close your eyes and keep the star pictured, do that. And while you're picturing it with your eyes closed, if you're comfortable closing your eyes, do 3 deep breath in and out cycles. And when you're done, open your eyes and just stick the star wherever. If you lose the picture of the star, just open your eyes, look at it, and start again. Okay, see, lots of eyes open, not everybody, but we will go on. So what do you notice?
Right here, right now.
Yeah, it's real hard when you're thinking about that star in your head to be thinking about other things. It really is a good mindfulness exercise. Keep you in the moment. Hard to plan your grocery list when you're thinking about your star. It doesn't change any of your stressors. It doesn't change the fact that you may have a paper due and other demands in your life. But it helps you get centered. So it's like kind of helps you slow down for a minute, huh? These kinds of things are the kinds of things that you can take out to the staff in primary care providers' offices. Now I can promise you, if you do a brown bank lunch, the physician or the nurse practitioner or the PA may not join the lunch, but their staff may really appreciate that. They may start practicing it. I have gone around quite literally for years teaching healthcare staff about 6 60-second stress busters, because when you're in a busy clinic environment, you can't go meditate in a closet for 20 minutes. I mean, you just can't, but you can do something for 30 seconds. And that's what people get good at, and that's what they can then turn around when they notice that there's a patient waiting in that exam room and do one of those. And you're far more credible when you've done it yourself and you know. So you want some of those that you like, and then you can turn around and teach it to the staff so the staff can use it for themselves and with patients. So I think that becomes real important and is lumped in there when we think about trying to integrate behavioral health into primary care. We aren't always going to be taking direct care of the patients, but taking care of the staff so that they can do better with those patients, and then be thinking about, is this person having anxiety because of the situation, or maybe they really have it as an illness that needs further treatment. So then what about outcomes? Well, again, in primary care, it depends a lot on the underlying source, but they may be looking at some of the physiologic things, like looking at blood pressure, looking at, is this person in here frequently with colds and flu and infections, because there is a connection with mental health, and is the primary care provider making that connection? Not because they're not astute, but they're not thinking, they're not in that way. They aren't typically in tune with that as much. But we can do a lot with helping with that education piece, and that comes through having the relationship. So measuring outcomes and success first starts with, do you have a successful relationship with some people in primary care that know they can count on you and trust you and call on you to help with their toughest patients and to help them and augment their practice. That's really what's important. So you want to help them engage with all aspects of care, and it becomes much more a partnership, whether you're in the same office, same building, or miles across town. So we think about, this is probably my favorite slide this time, the communication from the counselors. I think this is the very right focus when you think about integrating into primary care. What's one of the first questions you would ask the primary care provider? How do you want to hear from me would be it. Like, if I'm seeing someone that you refer to me, what's the best way to communicate with you? And how often, and what do you want to know? Some will want to know a lot, and they'll want to be kept updated. The best ones will. Some, due to other circumstances, and I don't want to say it isn't because they aren't good practitioners, they may just have so many competing demands, they only want to know if there's a true problem. And then how do you want to communicate? You have busy practices and busy lives, so do they. What's the best way to connect? Some people might tell you text. Do you want to text important information? No, and you want to think about HIPAA compliance. But I can promise you, I've certainly, as a nurse, been asked by physicians to simply leave me a message, just text me. I absolutely wouldn't do that. And you want to think, some will say, well, email me, I'll check my email. think about HIPAA compliance. Think about, there are encryption systems, but really? So you really have to think about that. Some offices will have you call and talk directly to the nurse. The nurse is often the one who's working a lot behind the scenes, doing things like calling in prescriptions to the pharmacy and stuff. They do have the ear of that provider, and they may be the very one to contact, and they can catch that provider between patients, that sort of thing. So that can be an important start. Last time I talked a little bit about SBAR, and that's from used a lot by nurses to others, and I just wrote out a sample so you could see what I was talking about. But you always want to communicate when there's imminent concerns. If you have seen this person and you're really concerned about them, you certainly want to let them know if the person was hospitalized, because if they've been hospitalized, there's a chance that the medications that the primary care provider has been providing will get evaluated and changed in some way, shape, or form. You also want to let them know if you are decreasing, like maybe you were seeing them once a week and now you're seeing them monthly, or you have discharged them because it mutually agreed that they've reached the goals of treatment at this particular series. Because the last thing you want to have is the primary care provider assuming you're still seeing them and them not worrying about any of their anxiety or other issues. So does that make sense? That, and that's why it's so important to work out how you're communicating, when, and in what means, so that it doesn't become burdensome, because you want to be the go-to that they have integrated into their practice. And you do remember they're generalists, and so they may not appreciate how important your work is. But they will in time when they start seeing the differences that you're making with the people that you share in terms of practice. And again, if there's medication information that you come up upon, you may share with them because you've taken more time maybe to explore that. You may be instrumental in teaching the office staff how to score the screening tools that Dr. Sharp is going to be talking about, because it is the kind of thing where maybe it's an unlicensed person who's taken that form even and scoring it. They're not interpreting it, they're not using it. But the last thing you want is for them to go, after the patient walked out the door after they've seen the provider, oh yeah, did you know they got a X score on this? Too late. Just like they would never do that if the blood pressure was elevated. They would never do that if this person had had a 12-pound weight loss since their last visit a month ago. Those kinds of things. So we want to make sure that they understand the significance. And again, it's helpful to know who can score and what the scores, just wear the cuffs so they are letting the primary care provider know. And you can share with the primary care provider how these can be used to reinforce good practices. Just like if somebody's blood pressure has finally stabilized, we reinforce. You must be exercising now, you're taking your medication, you're on your diet. So the same kinds of things, so that we're all working together truly for holistic health, and no longer just giving that lip service kind of thing. So my bottom line is, the ball's kind of in your court to take this out. How many right now are working with primary care providers? Yeah, so the ball's in your court to go out and make those connections. You won't connect to every single person, but you'll find that way that works, and you'll find ways so that there can be those partnerships, so that when they have that person that they've identified, they call you. And that doesn't mean that you're always going to be available to see that person that day. But what happens if they call you and you have a 6-week wait? They're going to go to somebody else, or chances are they're not going to refer at all. And okay, I'll write your prescription, and we'll just keep an eye on you. And that happens a lot. And I'm not saying anybody's bad. It's just they're just busy working with diabetes, that hypertension, all of those other kinds of things, worrying about the elderly person, did they get their flu shot and did they get their pneumonia vaccine, all of the other demands that are there. So that's kind of the takeaway, is get creative and start thinking about how would you start connecting. And it may be connecting even with the receptionist and the unlicensed people to make those kinds of inroads, and taking care of the staff so that they take better care of the patients. And then the providers kind of get on board when they see this working. And that's, I know that's like at Menninger, it was sort of in reverse. We were a big mental health team. Every team had a psychiatrist, a psychologist, a social worker, a nurse, our nutritionist if it was relevant, a CD counselor if it was relevant, the chaplain. I mean, we had all of that. With any given patient, it would change. And then we had somebody from internal medicine, and sometimes she was an afterthought. We learned that wasn't very good. And so now we're doing that. We're kind of flipping this around. We want them to know you're not the afterthought. You're as much a part of the team as the physical therapist when it's appropriate. Not every patient needs you, but when they do, they really do.